So today's session is about using non-invasive ventilation in COVID-19 patients. So I'll be taking you through the latest evidence and the guidelines that are there regarding non-invasive ventilation and specific to COVID patients. What are the recommended settings and how device setup is recommended. So I'll be focusing only on the non-invasive ventilation part since since presently there are multiple options which includes pharmacotherapy and other treatment modalities as well. So, but in this particular presentation, I'll be focusing only on the non-invasive ventilation. I would request all of you, you can post your question either in the chat box or in the question and answer tab. We will be taking all the questions at the end of the presentation. And so as we know, presently we are in India, we are undergoing a second wave of COVID-19, and there are a number of patients and all the healthcare facilities are currently overwhelmed with COVID-19 patients. I'll take you through what are the current evidence that we have. So we have regarding non-invasive ventilation. So in the past, what we have seen in the past 1 year, due to very limited or resource limited settings in terms of respiratory support, there is a increased use in a non-invasive ventilation specifically in COVID patients. Fine. So there are a number of publications that have come up in the past 1 year, which the effectiveness and the settings of non-invasive ventilation specific to COVID patients have been studied and uh, published. Fine. If we see in this particular paper, so what was seen is that they said that non-invasive respiratory support has been increasingly used, and it showed an association with improved 60-day survival in this particular study. So it was also associated with better survival in the patients. Taking you through the Hope COVID registry. So this is one of the registry which was done for non-invasive ventilation in acute respiratory failure. So what was seen is that almost 20% of the patients who were admitted with the COVID-related acute respiratory failure were treated with non-invasive ventilation. And what happened is, in this specifically in this subset of patients, half of them did not require any intubation. Fine. So intubation was avoided in almost half of the patient, and the author suggested that this could be a viable strategy specifically in the present time when we have limited resources, and there are a increased number of patients of COVID. Right? Right. I'll now focus on the guidelines and the recommendation, the present guidelines and the recommendations. So first, I'll take you through the Indian guidelines. So what the AIMS or ICMR protocol, which was published on 19th of this month, told us. So as per the protocol, what was done is that the COVID-19 patients were divided into three, based on the severity, into three parts. Now, first is the mild disease, when there is upper respiratory tract symptoms with or without fever and without shortness of breath or hypoxia. Fine. Then there is moderate disease, when there is an increased respiratory rate of more than 24 per minute along with breathlessness, and but the SpO2 is between 90 to 93%. So for such patient, admission in ward is recommended. While for severe disease, where the respiratory rate is more than 30 per minute and the SpO2 is less than 90% on room air, they are required to be admitted in the ICU. And what happens to the respiratory support specifically? So those patients who are admitted in the ward, or those patients who fall into the moderate category, so what need to be done? Regarding the oxygen support, the target SpO2 that is recommended is between 92 to 96%. Otherwise, those patients who have COPD need to be maintained at 88 to 92%. Fine. And the preferred device for oxygenation is a non-breathing face mask. Fine. While if we talk about the severe patients, those who need to be admitted into ICU, so there is a recommendation that consider the use of non-invasive ventilation. Under NIV, both helmet or face mask interface, depending on the availability, is recommended. Fine. Along with that, there is one more important thing that we need to focus on, is that intubation should be prioritized in patients with high workup breathing if NIV is not tolerated. So any patients in whom we have initiated a non-invasive ventilation as a modality for respiratory support, we need to closely observe the patient during the initial part, and in case required, intubation should be performed. And in case NIV is not tolerated, or the condition of the patient is not improving or deteriorating, in fact. And so this is what the ICMR protocol recommended. However, yesterday there was another protocol that was published, that is clinical management protocol for COVID-19. This is the latest version since it was published yesterday itself. So what happened is, what are the changes specifically in this protocol is that now the definition for severe disease is much more clear, as it is in line with the WHO protocol. Fine. So even ARDS is defined based on the onset, the chest imaging, the origin of pulmonary infiltrates, and the oxygen impairment. Fine. What is suggested, or what it is recommended, is that those patients who need early supportive treatment, specifically in those patients, in the severe patients, there should be consideration of use of NIV or high flow nasal cannula with helmet or face masks, depending on the availability. In patients with increasing oxygen requirement, and if work of breathing is in, increasing. Fine. So in the early support itself, there can be consideration for NIV and HFNC in the specific group of patients. Fine. Um, Again, the same thing is emphasized, that intubation should be prioritized in patients with high work of breathing, and if NIV is not tolerated, in the presence of hemodynamic instability and altered mental status or multi-organ failure. So a very specific subset of patient where NIV could be useful. In that subset of patient, NIV should be given a try, but along with that, even the patient need to be monitored very closely initially, so that in case there is any need for intubation, the intubation can be performed. Okay. The other thing is about the use of HFNC or non-invasive ventilation. So what is said is, when respiratory distress or hypoxemia of the patient cannot be alleviated after receiving the standard oxygen therapy, that time HFNC or NIV can be considered. The good part of the guideline is, the guideline has also recommended the settings, or emphasized on the settings that we need to use whenever we are using a non-invasive ventilator. Fine. So what the recommended NIV settings is, a PEEP or EPAP of 5 to 10 centimeter of water. Along with that, a pressure support of 5 to 15 centimeter of water, uh, to adjust to a tidal volume of 5 to 7 milliliter per kg. Along with that, an FiO2 of 0.5 to 1 can be titrated to target an SpO2 of 94%. So this is the recommended settings, NIV settings, for those patients whom we are treating with uh, non-invasive ventilator. Fine. The other guideline that I would like to focus on is the WHO guideline. So on the similar line, which we have seen previously as well for the Indian guidelines, the WHO guideline also uh, focuses on what is the definition of critical disease and ARDS. And what they have done is, uh, they have said that in selected patients with mild ARDS, non-invasive ventilation may be used. Fine. And they have used non-invasive ventilation as an umbrella term for both continuous positive airway pressure device and a bilevel positive airway pressure device. So WHO has used NIV as a umbrella term for CPAP as well as for bilevel PAP. Fine. The Again, the points that we need to focus on is the selected patients. Fine. So the patient selectivity is also is also mentioned in the remarks. That is, the patient with hypoxemic respiratory failure and hemodynamic instability, a multi-organ failure, or abnormal mental status should not receive HFNO or NIV. So they have clearly stated which patients should not be given a trial of non-invasive ventilation. Again, having said that, they have again the emphasis is again on the initial monitoring of the patient. So they have said that a short trial for about 1 hour should be given, and in case there is no improvement or actual or acute deterioration, uh, that time an endotracheal intubation can be performed or should be performed. Fine. So this is something what WHO has emphasized upon. Coming on to the next ERS paper, or European Respiratory Society. So this was published in January, in Feb this year. So over here, they have tried to address a question regarding the use of continuous positive airway pressure device in patients with hospitalized patients with COVID-19. Fine. So what they say is that in the absence of immediate indication for invasive mechanical ventilation, a trial for CPAP can be done using a helmet or a face mask in those patients who have COVID-19 and hypoxemic acute respiratory failure. Fine. But again, having said this, the emphasis on that CPAP should not delay mechanical ventilation in patients who are not responding to the treatment. So whichever guideline that we look into, so usage of non-invasive ventilation should be very closely monitored during the initial 1.5 hour, and in case there is no deterioration, no improvement or clinical deterioration, that time the patient should be put on to a more invasive modality for ventilation. Fine. This paper, this position statement I have taken from Scotland NHS. I have taken this specifically because since they have emphasized on how the availability of continuous positive airway pressure device or CPAP devices can be used in the management of COVID-19 patients. So they in this position paper they tried to address that yes, CPAP trial can be considered in those patients who have a sustained oxygen requirement of 40 to 60%, along with an increased respiratory rate which is observed during either conversations or breathlessness which is affecting the ability to eat and drink, or an incomplete response to time prone or unable to prone. Fine. Along with this, along with the patient characteristics where CPAP trial can be considered, the other thing is which they have elaborated upon is the CPAP setup that is required. So they have told that CPAP of 12 centimeter of water and oxygen of 10 liter per minute. That is for those on 15 liter per minute if the oxygen requirement is more than 60% FiO2 prior to CPAP. Right? So these are the recommendations from Scotland NHS regarding use of CPAP devices in management of COVID-19 patients. Fine. So we have seen all the guidelines or most of the guidelines around the globe. What is the recommendation regarding non-invasive ventilation? I'll now take you to the recommended settings, the second settings that can be used for non-invasive ventilation, both CPAP as well as NIV or bilevel PAP in patients suffering from COVID-19. So as discussed in the previous slides, the time of trial should be between something between 30 minutes to 1 hour. That is based on the various studies that are done over the various part of the globe. Then the parameters that need to be used is for CPAP device around 10 centimeter of water can be used. While whenever we are using a bilevel positive airway pressure, an EPAP pressure of 5 to 10 centimeter of water, along with a pressure support of 8 to 10 centimeter of water. This can be used in those patients in whom we plan to use non-invasive devices for management of COVID-19 patients. Fine. And FiO2 should be titrated to target an SpO2 of 92 to 96%. Right. And as said or as seen in all the guidelines and all the previous publications, so we need to consider the intubation as well, or we need to monitor the patient as well for any clinical deterioration or a non-improvement. Fine. So any respiratory rate that is more than 30 breaths per minute and or a sign of excessive respiratory effort under PAP, uh, along with a P is to F or PF ratio of less than 150 to 175 in the first hour, needs to be intubated. Fine. So these signs need to be looked into whenever we are using a non-invasive ventilator in a patient with COVID. Fine. Along with this, we also need to observe the patient, and we need to avoid any asynchrony between the device and the patient, any excessive respiratory effort that is there, or a ventilation of more than 9 milliliter per kg, or for leakage and aerosol formation. Fine. So these are the settings which can be recommended for a patient whenever we are planning to put a patient on non-invasive ventilation for management of COVID. The next thing or the next part of the presentation is focused on the device setup. So regarding the risk of aerosolization, so what is seen particularly in NIV devices is that whenever uh, these devices or non-invasive ventilation procedures are used, so it is uh, the uh, the kind of droplets that are formed are large or more than 10 micrometer, fine, rather than aerosol. So the risk of aerosolization is less. Along with this, it is also recommended by expert panel that a good interface should be used. So a good fitting interface whenever it is used, so even that will reduce the aerosolization or the risk of dispersion. Okay. Uh, in this British Thoracic Society Advisor NIV, they have focused basically on the masks and the filters that are used for that should be used for management of COVID-19 patients. So for masks, they say that well-fitting oronasal face mask or masks over total face should be used. Fine. So they have focused on this part, that is well-fitting oronasal mask. So, and how to look for a well-fitting mask, I'll show you the videos in my subsequent slides. Fine. Uh, Vented mask should not be used. So presently it is the non-vented mask that should be used along with the leak port. I'll show you the circuits as well in the subsequent slides. Fine. And the sequence of action should be, first we should put on the mask on the patient, then switch on the ventilator, and while removing the mask or while stopping the therapy, what need to be done? First switch off the ventilator, then remove the mask. Fine. So mask on, then switch on the ventilator, switch off the ventilator, and then remove the mask. So this should ensure that there is least probability of dispersion or aerosolization, and would save the healthcare professional or the caregiver. Fine. Regarding the filters or the antibacterial viral filters that we are used, so it is recommended that these should be placed between the mask and the exhalation port, so that whatever exhaled air that is passed to the external environment should first pass through the antiviral or the bacterial filter. So mask followed by a AB filter and followed by a exhalation port. So this should be the sequence of circuit. Fine. These filters should be changed every 24 hours or sooner. Fine. Since what will happen with the filter, uh, due to moisture in the exhaled air, this might get clogged. Fine. And which would produce a unnecessary impedance or the resistance to the flow of flow of gases. Fine. So that's why every 24 hours the antibacterial or viral filter should be changed. Fine. An external humidifier must not be used since it increases the risk of aerosolization. Fine. So this is the recommended circuit. First is the full face, well-fitting full face mask. Ideally, this mask should be a non-vented mask. For non-vented mask, the elbow should be blue. Although I have taken this picture directly from the BTS advice, uh, but they should be blue. Ideally, they should be a full, well-fitting full face non-vented mask. Then a filter, the filter through which to which this mask would be connected, and an exhalation port. So on the other end, this exhalation port would be connected. Fine. So the circuit would look something like this. First, we have the full face non-vented mask. After that, we'll place an antibacterial filter. Post that filter, we have an exhalation port through which the exhaled gases would be released to the external, and then we have this connecting tube. So this is how the circuit should be placed. First a mask, post that the filter, then the exhalation port and the connecting tube. So this would ensure that there is least dispersion or least dispersion of the aerosol from the patient to the external. Okay. Yeah. So here, in case we are using an oxygen entrainer, the circuit would look something like this. So the function of oxygen entrainer uh, is to provide oxygen in the circuit. So whenever we are using an extra oxygen entrainer, the circuit should look something like this: mask, after that a after that a filter, then oxygen entrainer, then exhalation port. So it should look like this. Okay. Now I'll show you the video about selection of the mask, how the mask need to be selected.
AccuCare F10 Hospital Non-Vented Full Face Mask. This mask is meant to be used with a dual limb circuit or a single limb circuit with integrated expiratory valve. The blue elbow indicates that the mask is non-vented without an anti-asphyxia valve. It is to be used with devices that have their own vent for CO2 washout. Follow these instructions to ensure the correct fit of AccuCare mask on your patient's face. Use the sizing template on the packaging to determine the correct mask size. Position the mask cushion over the nose and mouth and pull the headgear over the head. While holding the mask along the face, pull each of the side straps back along the side of the face. The straps should pass below the ears. The side arms on the mask should bend back as the straps are tightened. Gently adjust the top strap. Start ventilation according to the ventilator system operating instructions and connect the mask to the ventilator system. If air leaks around the cushion, reposition the mask on the face to achieve a better seal. Readjust the headgear straps if necessary.
So this was about the mask placement, the choosing the size and how to place the mask. Fine. So there are certain concerns about how can we control dispersion whenever we are using different type of circuits. Fine. So if we talk about the double limb circuit, so this slide shows what is the risk of dispersion based on the placement of filters at various limbs of a double limb circuit. So a least risk of dispersion would be seen in this kind of a circuit where we are using AB filters at the expiratory as well as the inspiratory limb, and an HME filter just after the mask. Fine. So this would ensure that there is least risk of dispersion. Fine. Uh, this circuit shows that there is a HME filter that is placed just after the mask, and in the expiratory limb we have placed an antibacterial filter. So the risk of dispersion is more than this circuit where we have placed three filters. Fine. In case we are placing only one HME filter only after the mask, so it has the maximum risk of dispersion, although lower than no filter at all. uh, the thing that we need to keep into mind is that whenever we are using filters in a device, there is a feature in the device which is called as learn circuit device. Learn circuit. Fine. So we need to run learn circuit whenever we are using different type of filters in the device, with the device, so that the device knows about what is the kind of resistance that is there in the different limbs, in the various limbs, and accordingly it will adapt to the uh, overcome those resistance, since these filters would pose resistance to the airflow. Fine. So that is why learn circuit need to be used whenever we are placing the filters uh, in the circuit. Fine. So this is about the dispersion risk in the single limb circuit. So as you can see, we have various single limb circuits over here. So the least risk of dispersion is whenever we are using an AB filter in the inspiratory limb as well as an HME filter after the mask. Fine. Uh, while the risk of dispersion is more in those in those circuits where we are using only single antibacterial filter only after the mask and not anywhere else. Fine. Again, I would like to emphasize whenever we are putting, irrespective of a single limb or a double limb circuit, we need to use the learn circuit feature of the device, so that the device is aware about what is the kind of resistance that is there to the flow whenever we are placing the filters. Fine. Coming on to the stellar devices. So this is how an antibacterial filter can be used in a single limb circuit. So an antibacterial filter just at the opening, and post that the tube can be placed. Fine. Whenever we are using the air cover or the Lumis devices, what we need to do is in the under the configuration, the configuration part, in the accessories, we need to turn on the AB filter as yes. Fine. So that the device is aware that there is a antibacterial filter that is placed in the circuit, and would overcome that, or would plan accordingly, so that resistance can be overcome. Fine. This slide will show about how exactly we can supplement oxygen in the various devices. So regarding the stellar devices, so what they need to be done, there is a knob at the back end where the oxygen tube can be connected. For the Lumis or the air curve devices, what need to be done is in the vent, first AB filter would be placed. After that, oxygen entrainer, which would look something like this, where the oxygen uh, uh, port can be inserted. After that, tube would be there, and another AB filter would be placed. So, and over here would be the mask or the patient interface. And so this is how the circuit with two AB filter and oxygen entrainer would look like. Okay. Uh, Regarding mitigating the risk of droplet dispersion, we all know that mitigating the risk of dispersion is very important, specifically in COVID patients. So fine. So there are certain things that we need to look into. First, into the personal protective equipment, or PP, safety, uh, the safety for the personnel who's handling the device or the patient. Fine. So we are all presently taking care of all these things, like disposable, wearing a disposable surgical cap, N95 mask, disposable medical protective uniform, disposable latex gloves, face shields, and goggles. Fine. The patient setup that we need to look into or take care of is using a full face mask. Fine. The second thing is ensuring proper fit. The fit, that as we saw in the previous slides, that how exactly the right size for the right patient can be selected. Then using a filter between the mask and the exhalation wall whenever we are using a single limb circuit. Right? So these are a few things that we need to take care of to limit the risk of dispersion. Uh, in the subsequent 2-3 slides, I would like to focus on the correct use of device for the patients. Fine. So last year, what happened when this pandemic started? So FDA had given approval to a few of the devices which were earlier not used, or they have authorized a few ventilators which can be used in COVID patients. Fine. So which can be seen, or which can be checked on the US FDA website. And so I have specifically by the name of the organization or name of the company who's manufacturing it. Fine. The other thing that I would like to focus on, since we are presently are in a resource limited settings, and we don't have enough number of devices to manage the patients. Fine. So one thing that we need to look into is that using the correct device for the correct severity of disease or the correct subset of patients. Like over here, those patients who are critical cases and require invasive ventilation. So we have devices like Estrella and Stella. Similarly, external stellar can also be used in those patients who have who are stable and transpositioning from hospital to home. Fine, but since this comes in more handy in those patients who are critical and require invasive ventilation. For this subset of patient, those devices which presently don't have the ability to handle critical cases can be used, like Lumis or Aircurve ST. Fine. So selection of right selection of device is very important based on the patient's the improvement or the present condition of the patient. Fine. So this was about the presentation. So let us take up a few questions now.
Thank you, Pulkit, for a comprehensive presentation and with the latest information that is available today on COVID. So, with regard to question, let me take up the first question for you. This question is from Dr. Kunal Luthra. He would like to know dual limb versus single limb circuit for non-vented mask. Which one is better?